So we've got two short screencasts here, which I'm hoping are going to take you through the journey, pulling together some of the things that you've learned on your modules so far, but applying them to dietetics. So we are thinking a little bit about what a behavioural approach is, what person-centred care is, and how our communication skills link with that in order to provide the best care that we can. So if we think a little bit about dietetic practice and what we know what we're trying to do so often is to support people and to facilitate people to make changes in their diet, their physical activity, lifestyle. And you might wish to go back to your first block of Life Course Nutrition and remind yourself about the COM-B model that we looked at there for behaviour change and what behaviour change is, because I'm not covering that now. And we also looked at the wider determinants of health and their impact on behaviour change. So hold those in your mind as we're going through this. So what we're really focusing much more now is about individual interactions with people and how our approach can facilitate behaviour change in dietetics. So let's start by thinking, what is a behavioural approach? And it's based on a person-centred or patient-centred clinical method. So initially it was created by medics to try and think about a different way to support patients. So they called it the patient-centred clinical method. And it is a directive method. So it's not a listening skill where you just let people talk and encourage them to talk. It is directive because of the fact that we have a purpose and we are there to support health, promote health, support people to look after their health. So it is directive. We've got a purpose, we've got a structure. It's not an open-ended talking theory. So the main principles of a patient-centred clinical method have been described as exploring both the disease and the illness experience. And this is part of that kind of not labelling someone as a diabetic, but thinking of a person who's living with diabetes and what is their illness experience? What does that mean to them to be living with a particular medical condition? The idea of understanding the whole person. If you remember when we talked about the COM-B model, it talked about understanding their capability and what opportunities are open to people. And we'll come back to that in a minute. But it's thinking not just as a person with a disease, but a person who's got an existence outside their disease, what their life is and all of those kinds of things. So we're looking at that kind of idea where we're beginning to understand that person, their illness experience, and within that we have got to try and find some common ground. So we may have an agenda from the point of view of wanting to encourage health-related behaviour change, and we've got to find the bit of that person who connects with that so that we've got a common ground, a starting point. And with behavioural approaches, you're very much looking at prevention of poor health, prevention of conditions developing and getting worse, and promoting health. So we've got those mixture of those two things. And as dietitians, we will do that. We won't just treat celiac disease, for example, but we will be looking to make sure that that person can maintain their diet long term to decrease the risk of them having health-related problems, such as anemia or osteoporosis, or increasing the risk of bowel cancer because of them not being able to follow that diet. So we've got to try and promote health alongside preventing ill health. Core part of it is our relationship with our service users, which would come on and talk to about more later, and being realistic in the way that we do things. So it's talking about setting goals that are achievable and relevant to the patient, that kind of thing. So a bit of how do we go about that? One of the key things is about individualization, and that word's just going to come up again and again in lots of documents that we will see. So how do we do that? If we're going to individualize our advice, we've got to understand people's current behavior. And at the moment, we're focusing on this module on undertaking a typical day and understanding their dietary behavior, their eating behavior. But it will become a more holistic approach. So we're not just dealing with diet, but we are looking at something much more broadly and what impacts that diet. And as I mentioned, the COM-B stuff, we're looking at capability, we're looking at the context people live in and therefore the opportunities they have or don't have, and therefore how those are linking with motivation and behavior change. So all of that is part of how we try and encourage a behavioral approach. And the specific needs I'm talking about is things like their gender, their culture, their faith, anything that might affect their health-related behavior, any disabilities or anything like that, that mean that there's more to consider than just a medical condition. And if you've looked at the new standards of proficiency for dietetics that came out in September, there's a lot in there about equality, diversity, and inclusion. And part of that is making sure that we understand people and what their needs are and try and work with those. So there are some guiding principles if we're going to be working in this way. And this tells us how we should work if we want to support behaviour change. So the first thing is respecting autonomy. And that's about that individual's right to make their own choices and their own decisions. So we're not telling people what to do, we're working with them so that they're involved in that decision and they make the decision that they perceive to be right for themselves, which may be something quite different to what you are hoping that they will do. So sometimes people choose to do things that are completely contrary to what the advice would be to manage their conditions, and we have to respect that. The second thing is about client or patient responsibility. And that's just defining the fact that people are responsible for their own actions. We need to try and understand the situation, the challenges, and support them while respecting their autonomy. So we don't take away that responsibility. And you can do the best that you can in a consultation, and someone will go away and not choose to follow the advice or to follow even the goals that they have agreed. That's their responsibility, it's not yours. And that's a really important thing for our well-being as well, to remember that you do your best. But if people don't work with that, that is not your fault. Social influence is a term that's often misunderstood. So a lot of people would think it means the influence of society, but actually in this context, it means something quite different. It basically means that you and I have a role, and we are employed to influence health. So we have that social responsibility. We're employed, that's what we're employed to do, and therefore we should be doing that. So the society is in effect the role that we have that is there to try and influence health behaviour. It's not about the wider society's influence on people. Collaboration is about pulling together the health agenda and the patient or service user's agenda. You use the expertise that they have on themselves, and with their consent, use your expertise at the same time. So you work together, trying to find that common ground. Self-efficacy is about self-belief. So we need to try and help people to build their belief that they can actually make changes. And thinking of a situation where this might be really quite difficult would be for somebody who has struggled with weight management for a long time. They've tried lots of different things and either nothing succeeded, or if it did succeed, it didn't last. So people then become less believing that they will ever be able to do anything about it. So it's a long-term struggle, and now, I can't do anything about it. they've tried and it's not worked. So we need to be able to work with people to try and encourage that self-belief. And empowerment is about helping people to take control of their situation. And we work with lots of different people who have long-term conditions, and therefore the dietary or lifestyle changes that we need to make are long-term. So someone with celiac disease, diabetes, cardiovascular disease, renal disease, it's a long-term change. It's not a short-term fix. So we need to try and support people to take control of that, because we have a very short space of time with people, but then they've got to go home and live with this situation. So supporting people to take control, to manage their condition themselves, is one of these guiding principles. So in order to be able to do all of those things, to actually use those guiding principles, we need skills. And these are described here as core conditions. And these are the things that you have and need to continue to work on to develop further, as we all do, as part of your skills development. And that's what we're looking at in this module, really. So let's just check that we are clear on the terms. So empathy is about putting yourself in the patient's or service user's shoes, trying to imagine what it's like to walk in their path, their journey, and their point of view. Very much not the same as sympathy, which is about feeling sorry for someone. When people think of feeling sorry for them, they can often feel patronised. That's not what we want. We want to try and be able to convey that we understand the difficulties that they're going through or the journey that they're on. Genuineness is about being yourself, being sincere. So your non-verbal and your verbal need to match. And people are very quick to pick up if that's not the case. So if you're saying something really that sounds like you really understand, but your body language is saying something different, actually you're completely disinterested, that will be seen as insincerity and people will not trust us. So we've got to have that consistent sincerity or genuineness. Acceptance, that fits with our NHS values about treating people with respect, being non-judgmental. And some people call it unconditional positive regard. So there is no conditions on your regard for that person. You accept them whether they are living a life that you would live or they live something that you feel is unacceptable. So we have to accept them anyway. Compassion is very much about being caring and concerned for that individual and their situation. And the non-verbal and verbal stuff we're going to come on with the communication. We're going to talk about that in a bit. So moving on from that patient-centred approach, more recently we have NHS Health Education England coming up with a person-centred framework. And this is a brilliant document in my mind. It's got loads of stuff in it about how we should be person-centred and what that means to our service users. And one of the key statements is that patients and the public should be actively involved in all decisions and treatments that affect them, and are offered informed choices that empower, place them at the centre of their care. And if you look at that statement, you can see how much that agrees with and is consistent with that patient-centred or person-centred approach. So that's one of the key documents that I think you need to at least have an understanding of, to be thinking about how does being person-centred affect me in my workplace.